Okay, this is just a quick summary of a couple suggestions for improving radiology reports. I'll also mention a few things about preparing for diagnostic radiology written boards. So we'll start out with how to improve radiology reports. First of all, try to be brief. Avoid bulky paragraphs. It's hard for anybody to read bulky paragraphs. The other attending physicians have a hard time reading them, so imagine the trouble an internist is going to have reading that. Okay, next thing is embodied simulation. Embodied simulation means that when we hear someone else speaking to us, we, in our mind's eye, visualize what they're saying. And it's much easier to do so if we hear the subject first, a noun. Like if we hear the dog chase the cat. As soon as we hear dog, we think of everything a dog does. It barks, it chases cats. And the same goes in the body, that you should state the anatomic location first before describing the finding. For example, if you say no evidence of neoplasm in the liver, nobody knows what you're talking about until you say the word liver. So it's better to say liver with no evidence of neoplasm, and to do that for every anatomical region. Other thing is, every doctor tends to be overworked and in a hurry. They want to get all their work done so they can go home. But also think not just about yourself, think about the referral service, the internal medicine doctor, nurse practitioner, whoever's going to have to read that report. And just think, how will they perceive this? If you just simply think of how the other person is going to perceive your report, you'll touch it up in a way that makes it better. And by doing these things as a habit, you'll be able to do it fast. It's not going to slow you down significantly. The next point is anything that adds to the truth subtracts from the truth. So say what you have to say, but be as brief as possible. And anything that's not going to affect management, then don't put it in the impression. You want the impression to be just to the point. Because if you put too much information there, I've seen this plenty of times, you confuse the referral service doctor, and sometimes they miss the significance of the real finding. You don't want to bury the lead, so to speak. Okay, next question arises, should I tell them what to do? And what that means is, should you recommend a consultant or some other special process? And I would say it depends. You just have to know your referral service. In general, if you think the report's going to a primary care service who's not going to know what the findings are, tell them what to do, because they're not going to know. On the other hand, if it's going to a specialist like orthopedic surgery, they're not going to want you to tell them what to do. Their attitude is that they know what to do already, and they don't want you pressuring them to do something that they might not want to do. So just use your judgment on that. Next question, good communication, per Claude Shannon, the inventor of information theory, based on his work with telegraph systems. And what he basically said was, good communication increases certainty, reduces noise. So again, that's a little bit like anything that adds to the truth subtracts the truth. Make your point clear and don't say anything more in the impression. Okay, appositives and parentheses. Appositives are quite interesting. Appositives comes from interjecting a little extra detail, for example, between a couple of commas. And where this comes from is there's a guy by the name of Francis Christensen in the 1960s. He was a teacher of English grammar and literature at University of Southern California. And what he noticed was that none of these grammar literature teachers were any good as writers, which is kind of amusing. And he said, well, why, if we are the so-called experts of literature, how come none of us can write well? And so he decided to study the great writers. And what he noticed was the really good writers, like let's say Dostoevsky, they have a lot of little interjections into a sentence where they just add a little nuance. And that little nuance between a couple of comments, extra details, makes the sentence, brings it to life. And so what I'm saying is when you need to add some nuance, but you don't want to derail your train of thought, keep everything connected, you can just put in a positive in. So let's just stick a little comment in between a couple of commas, and that can often make the report a lot better. It's a way to add nuance. You can also put some nuance within parentheses. It's an easy way to, because you want to stay in your train of thought with whatever item you're describing, but using parentheses helps you. These little punctuation tricks, they'll make your reports a lot better. The second thing is semicolons. If you need to give a relatively detailed description of a complex mass, putting it into semicolons shows that the sentences are connected, because you want to keep everything all connected. You don't want to have to repeat the subject and make a completely new sentence. So semicolon means two sentences are connected. Okay, the next thing is use definite words. When you're looking at a kidney cyst, if it's benign, say it's benign. Don't say simple cyst. Even though the radiologist knows that simple cyst means benign cyst, the internist does not. And if you say simple cyst, that patient might be stuck getting followed up for 5 years. Call it a benign cyst for everybody's sake. The other thing is Body imaging is different than neuroimaging. In body imaging, everybody expects incidentalomas and a follow-up. You know, the old joke is, what's the definition of a healthy person? Someone who hasn't had a CT of the chest, abdomen, and pelvis yet, because there's always going to be some incidental thing that requires follow-up. Whereas it's not like that in neuro. Neuro referral services, neurosurgery, ENT, neurology, they don't like follow-up cases unless there's a good reason for it. So sometimes people fresh out of fellowship try to call every little bump and funny corner on a bone, you know, a possible abnormality needs follow-up. And I'm just saying from experience, you know, ask one of the senior docs. When I first got out of fellowship, I was real confident. And I noticed sometimes the older docs would ask me, you know, how to describe a complex pathological finding, for example. But I was surprised to find that I had to ask the old docs for help much more often than they asked me for help, because the most common thing of uncertainty reading a film is this a normal variant or not? Or is it pathology? And the old guys knew that stuff really well. So that's interesting. All right, next thing. Do what you can to help the referral doctor based on what you know about them. If you think they want you to comment on something like they got a CT of the neck for rule out mass, tell them if there's a mass in that location. Comment on whatever it is that they're interested in because you know it. And also, if you know it's going to somebody, some primary service who doesn't know that anatomical region, don't use jargon terminology that they're not going to understand. Explain it for their sake and so they don't call you, okay? Your conscience is a good advisor. If you think you might lose sleep about something, that's your conscience telling you, yes, you need to comment on it. You need to elaborate on it. Maybe you need to get more imaging on it, whatever the case may be. But that's a good thing to pay attention to. You don't want to, you know, leave the hospital at night thinking, should I have commented on that? You know, no. If you get that feeling, that means yes, you should. Always try to find the old film whenever possible that'll set you free, because a lot of times you'll be perseverating over some anatomical finding. Look at the old film. It's been there 20 years. It's nothing. And then, you know, do the kind of job with reading your film so that when the next person comes the next day and they're going to have to look at some of your reports, let's say for covering plain films, that they're happy you were on the day before them. So get in the habit of doing that. It'll slow you down the first couple times you do it, but afterwards it'll just become a habit. Okay, here's just a couple sample reports. Like here's a chest x-ray. So I just go to the comments right from the beginning. You want to be brief, separate your individual sentences. I like to start at the top of the film and then work my way down. I think that's easier for the person who reads the report. Every line has a separate paragraph. I'll say, for example, cervical spine ACDF. That way, the C-spine is covered at the top, indwelling right chest tube with tip in the apex. I like to say where the tip is on a chest tube. No pneumothorax. You want to group items that are related. As soon as you mention chest tube, the next thing they want to know is there a pneumo, yes or no? Okay? When you mention a central line, I just keep it brief. RIJ for right internal jugular vein. Central line with tip and SCC. I like to say where the tip is. And by abbreviating it, I can say it quickly. Anybody who reads these reports really ought to know these abbreviations. They're pretty standard and common. ETT, I don't, you know, why say endotracheal tube when I can say ETT for something that they know what it is and I'm mentioning it's right above the carina. That way my report can be real brief and clear. So that's the point on that. Okay, abdomen plain film. The way I like to read these is, again, starting at the top and working way down. Comment on the stomach, small bowel, then the large bowel, all in that order. That goes in continuity and from top to the bottom in general. It's much easier for the person reading the report to follow that. When I mention an enteric tube, Dobhoff, for example, in the stomach, say where the tip is. So that'll make your abdomen plain film reports better. For an abdomen ultrasound, we kind of talked about this already. You know, say the cyst is benign, say the organ system first. If you have a measurement, which they might not know, like common bowel duct diameter is normal at 4 millimeters, tell them it's normal. Okay, a little bit on spine MRI. Most common thing residents do that kind of annoys me is they'll comment on the central stenosis and the foraminal stenosis in the same sentence. Don't do that. The brain can only think about one thing at a time. You know, the surgeons mostly care about central stenosis. They seldom operate on foraminal stenosis. So mention if there's central stenosis or not, and then separately comment on the foraminal stenosis. They don't belong in the same sentence for the individual levels. In your impression, only include what is going to affect management. So here I said no moderate or severe central stenosis. That way the surgeon knows this is not an OR case. Because the real questions with a lumbar spine MRI typically are, does this patient need to go to the OR? Yes or no? Are there any red flags? Yes or no? If we're going to send them to the pain management doc for steroid injection and whatnot, what levels should they inject? So make your report so that they can easily answer those questions. If there's anything unusual on the film, like probably a benign hemangioma or something, just mention it and explain it so they're not going to feel like they need to call you. Okay, brain MRI, all the MRI sequences, just stick that all up in a corner. Nobody's going to read that or care about that. You don't want to clutter up the report with stuff that's not important to anyone. Findings, again, same point of state the anatomical area first, periventricular and subcortical, moderate amount of flare hyperintensities, suggestive of chronic small vessel atherosclerotic disease, pretty standard MRI report there. Mild diffuse cerebral atrophy with associated stable ventriculomegaly. They're always going to want you to compare it with the old one, so make sure you compare it with the old one. Ventriculomegaly just means the like ex vacuole dilation of the ventricles, rather than hydrocephalus implies that there's a problem. So, you know, ventriculomegaly, no problem. Hydrocephalus, a problem. If you find metastatic lesions, describe where they're located. This is an important thing to do. It helps the radiation oncologist. The surgeon likes to see that. And also, if you get in the habit of always describing relatively precisely the anatomical location of metastatic lesions and other findings, you'll stay good at it. You'll remember it. If you just say right frontal lobe lesion, that's pretty lazy, and your ability to precisely describe anatomy will decline. You have to do it on a routine basis to stay good at neuroanatomy. So anyways, that was all I had, I think, for the report stuff. There's two other things. Is when I gave that talk previously on how to crush radiology residency, I forgot to show these books. This is my copy of Donner from the 1990s, and this is what I used, you know, to crush diagnostic boards, get 99%. And here's it is. I put everything in here. I'll try to, I can only keep this small thing. So everything is indexed into this book. It's in an outline format. It's alphabetized at the back. And all of that, what I was really pushing towards with this form of condensed notes is to be able to find everything. Everything I learned in the whole residency was in this one book. And I would add other things into the index so that I could always find everything. And that was the key thing, that when it came time to, you know, the last couple of months before the boards, you know, here's a typical page, I had everything in one spot, so it was very easy to study. So I just wanted to show you that. You know, I screwed up, forgot to show you. You see how dog-eared it is? I have to tape the thing back together. For my boards in neuroradiology, I got tabbed indices. You can see them here. And I just taped all the pictures into one book. And the reason for this is this way, again, everything was in one spot. So pretty much everything I learned for neuroradiology that was relevant, I would have it all in this one location. So I could go through all the anatomical regions, all the diseases, all in one spot. Especially anatomy is what I was focusing on here. But again, the idea of having it all in one spot, so when it's crunch time the last couple months before the boards, it's all in one spot. I found that very helpful. So I call that condensed outline format notes, and then the second one was condensed illustrated notes. So anyways, hopefully that'll help you with your studying.